It's all pieces. All right, I'd like to call this meeting of the Executive Committee to order. And we will start with our, we'll just proceed in the normal order of the agenda. And so first we have a Zoom appearance by Maribel Campos, who's a PA and who is accompanied also, I think, by Joel Jones, Dr. Jones.
Madam President, for the record, could we just state that Dr. Kennard is here acting as secretary for the committee today? Is that correct? Or thank you.
But do we need to also say who's standing in for Dr. Cleveland?
Well,
Just saying.
Mike Lucius, deputy director, is here in place of Dr. Kenneth Cleveland.
All right.
Thank you.
So, and just before we get started, I'm sorry, for logistical purposes, we do have several people on Zoom. If you could all introduce yourselves just so that we know who's present, and we can do this at the beginning and then we'll just proceed in the usual manner.
Sure, I can get started. My name is Maribel Campos. I am the first case that you guys have in place. I'm a physician assistant and I'm here with Dr. Joel Jones as well.
Hi there. Hi, Dr. Joel Jones here. I'm joining you from Bentonville, Arkansas. I'm a family practice doctor here. Nice to meet you all.
Hey, Bill, how's life in Walmart? Sorry.
It's definitely Walmart world, that's for sure.
All right. Can our other guests please introduce yourselves as well?
Good morning. My name is Stephen Taylor. I'm a psychiatrist, and I'm the Chief Medical Officer of Pathway Healthcare. And I'm coming to you from Jonesboro, Georgia, and I'm here with Dr. Deborah Gross.
Thank you and welcome.
Good morning. This is Cherie Wade. I am an attorney here on the Gulf Coast, and I'm here with my clients, Dr. Chris Hall, Dr. Nicholas Chamberlain, and then our APRNs, Michelle Paisani and Shadia Tawab.
Hi, this is Chris.
Okay, sorry.
Sorry about that. This is Christopher Hall, Dr. Christopher Hall. I'm an infectious diseases physician and chief medical officer at Avita Care Solutions, which is the parent entity of Q Care Plus. And I'm joining from Atlanta, Georgia today.
All right.
Good morning, Dr. Nicholas Chamberlain, ID in internal medicine, working for Q Care Plus, based in Atlanta, Georgia.
And I'm Shadia Tawab. I'm a nurse practitioner with Q Care Plus, and I am in Alabama.
Hello, I'm Michelle Paisani. I'm a family nurse practitioner. I'm joining you from Q Care Plus, and I'm in Orlando, Florida.
All right. Is that everyone? So everybody had an opportunity to introduce themselves? All right. Thank you very much, everyone, for that and indulging us this morning. Now we will go ahead and move forward with our first case for today, which is the appearance again of Ms. Maribel Campos, who is a PA and accompanied by Dr. Jones. Ms. Campos, can you just tell the executive committee why you're here this morning, please?
Sure, of course. So I was licensed with Mississippi a while back, but then I was made aware of the stipulation of the 75-mile rule in addition to the 80-20 rule. I live in California. That was the one part I missed from everybody introducing themselves. So I'm in Northern California. And Dr. Joel Jones is in Arkansas. So we are clearly over the 75-mile rule. And then also Dr. Jones lives in Arkansas, not in Mississippi. So those are the two things that we are here to appeal to.
So, and if you could specifically kind of describe in detail what services you provide, what your practice setting is like, so that we understand the relevance of the the issues that you're bringing before us? Just what exactly are you all providing? What services and how is it being provided?
Yeah, absolutely. So we are both in primary care, family medicine, and we do telemedicine. So we work asynchronously through telemedicine. We do video conferences with patients. We do telephone visits with patients. It's primarily in primary care. So that is what the practice essentially does, and the kind of patients that we see. Did you want specifics on like actual patients within primary care, or?
Yeah, because I mean, in all fairness, primary care is pretty broad, and most primary care providers don't practice the full breadth and depth of primary care. Like they don't see everybody, right? Like everybody doesn't see little kids.
Yeah,
Everybody,
no, absolutely. Fair enough. Yeah. So actually,
yeah.
so
More
I don't-
specifically, what your practice is like, and what services you provide through this through your telehealth.
Yeah, absolutely. So I would say it's more because I do telehealth. I'm not necessarily doing annual physicals and stuff like that because I don't see patients in person, but I'm doing a lot of more of an urgent care base. So UTIs, ear infections, tooth abscesses, skin conditions. We do offer weight loss options. Things of that sort. I don't necessarily do a lot of children because of the same issue. They're under 18. I'm not able to see them in person, that sort of thing. So it's mainly adults that I deal with and more of an urgent care basis, things that I can, that can be treated with antibiotics. Like I said, skin conditions. We do offer weight loss options for, chronic obesity and things of that sort.
Can I jump in here?
Absolutely.
I would just add that Maribel and I, we collaborate with each other across the United States, probably 30 states so far. So our time would be divided. All of our time is not going to be in Mississippi. We're going to be divided across all the states. So we just want to help some people there too. That's it. That's it.
That's a good point. Yeah.
So, can you give me a little bit better understanding about what the process would be? Say, for example, if I was a person in Mississippi who wanted to engage with you for care, what is that process and what does that look like? Walk me through, say, for example, an encounter. I pretend that I am a 25-year-old with urinary tract infection symptoms. How exactly would that process go through, or how would that be structured according to the way that you currently have your practice set up?
Right. So right now I work with two different platforms. One of them is Push Health, where they send me patients. And if someone was in Mississippi, let's say you were within Mississippi and you clicked on Push Health online because you wanted to see a medical provider through telehealth, you would be directed towards me if I was licensed in Mississippi. So then you would come on my panel, and then I would start communication with you. I would look over your file. I would look over your medical history, any allergies, et cetera. And then I would reach out to you if I felt like that case was appropriate, if it's something that I felt like I was comfortable with taking. At that point, I would start communicating with you and obviously ask you relevant questions in regards to your symptoms, how long they have been there, if it's something that's appropriate, right? If it's something that is beyond my scope of practice or something that feel like it needs a little bit more care or something that needs to be seen in person, I would relay that to the patient. But at that point, I would schedule a video visit and have a conversation with the patient and ask them all those questions. And then if that patient seems like someone that I feel like, if they're having UTI symptoms and I feel like they truly have a UTI symptoms, then I would come up with a treatment plan and appropriate antibiotics that would be fitting for them. And then follow-up care after that. So I would usually reach out to the patient afterwards, letting them know that I sent a prescription to the specific pharmacy, and then an invoice would be sent to the patient for them to pay for that. Something to mention, I do only do, excuse me, cash pay with patients. I deal with all non-insured, and that's something that, you know, I actually really love. There's a huge community out there that is uninsured, and I feel like this could really be helpful to them. So my platform is cash pay uninsured. I send them an invoice, they pay for that. They're able to have my consultation, the prescription sent to them, and then follow-up care for that treatment. But I would say that's pretty much the setup of seeing that patient. After that, I put in a detailed SOAP note on my patient, letting them know exactly, you know, what was done that that day, subjective, just essentially a SOAP note on the patient, and I would sign that. And then if Dr. Joel Jones wants to look at the chart, he has full access to my entire patient panel.
Thank you for that. So one thing that I wanted, so have either of you ever worked in Mississippi? Either of you?
No, ma'am.
Myself, physically, no.
Okay. And so say, for example, if you have, so you mentioned asynchrony, and so I have a couple of questions. I'm trying to keep them in line. So the first would be, you said that they're asynchronous. So if I had reached out as a potential patient, then what is the process whereby, like, is there a certain time frame in which, like, do I submit a request or an early synopsis of whatever my symptoms are, and then they are reviewed, and then you reach back out? Am I placed in a queue where I'm on virtual hold? What exactly is the process for how you would respond? I'm just trying to understand that process from a telehealth component, as opposed to, say, for example, if a patient were to walk into an urgent care center.
Right. So yes, when a person signs up with Push Health, they are put into a queue, and there are plenty of providers that are on there that can see patients. And so it really is a matter of minutes, if not seconds, honestly, before a provider grabs that patient if they deem it appropriate. So they're in a queue, and then if I read that patient, I say, okay, she's a 25-year-old with, you know, pretty familiar UTI symptoms that I feel like I could help. Then I would grab that patient and I would start communication immediately.
So you guys provide care to over 30 states. And right now we're talking about 2 of you that have Mississippi licenses. So if there are 12 people at 3 p.m. who log on to Push Health and have a concern, how exactly do you handle that? Especially if you are, say, you're serving as a person who also is working in, I don't know, Indiana or some other place. How does that work? I mean, are you guys, because if that's the case, it would be that you all are the ones who are only providing care to the Mississippi contingency, correct?
No, that's actually a great question. No, there are, I would say, Dr. Jones, would you say probably hundreds of providers within Push at least?
I'll be honest, I don't know the number, but it is a nationwide company, and people can provide care on there from anywhere. So there could be an unknown number of providers that would be available to see your patients, not just us.
Okay.
Yeah, there's many providers. It's not just myself.
No, I think I understood that. I was just trying to figure out how it impacts, you know, the people here by having you all be a part of this. So and these are all really just questions to try to get a real understanding. Like, we can read the documents, but to get an understanding of how this really works, so that we can make the best decision. So, and I will at this moment take an opportunity and let some of my other colleagues ask any questions, other executive committee members, if there are any questions.
Thanks, Dr. Owens. I'm Ken Lippincott. I'm a psychiatrist. But I was just curious, do you have access to laboratory studies, like if someone has a urinary infection?
I do. We do. We have access to Quest Diagnostics. So if that is something that I can, I find appropriate, I would definitely send a lab specimen to Quest Diagnostics for a patient.
And where would the patient go to have that done?
To local Quest labs, they're through push. So essentially, they're essentially told which labs that they that qualify that they can go to.
Okay.
Quest Diagnostics.
And how often do you do that?
I would say not super often. I would say UTIs aren't one of the top things that I would say I probably deal with. But yeah, when a UTI comes up and I find that appropriate, I definitely will send those labs. I would say if I had to give you,
We're not closed to the number. You can feel free to just guess. It's
yeah, no, I would say maybe 4 times a month, 5 times a month, maybe a little bit more than that, but it just depends on the month. If I like I said, I don't get a ton of UTIs, so.
Okay, thank you. And you have, like, if you need a CBC or
Yes.
metabolic panel, is it do you have any difficulty getting those?
No, not at all. It's very easy to order those within the push platform, and I'm able to send those over. And patients go get those. I get the results uploaded to my system, notifying me that new lab results are in. And if I would like to notify the patient to let them know if the lab results are normal or if there's any abnormalities.
And when a patient is referred to you by push, do the patients, do they typically use their phone or their computer or what?
Oh, both, yeah. So it's truly telehealth. So any of their devices, they're able to communicate with me.
So are you able to get a good visual exam?
Yeah, absolutely. With video visits, I have no issues.
And I had another question. You mentioned weight loss options. Could you tell me about that?
Yeah, so I do offer weight loss options. I don't offer any stimulant medications, so I don't do any phentermine or anything like that. But we do offer GLP injections. So like Ozempic, Mounjaro, the new medications that are out right now that are very, very successful with weight loss with patients.
And do you like get the metabolic studies before you prescribe those?
Not necessarily. So if the patient has already had labs within like the last 3 to 6 months, I'm able to see those with the patient. I usually will ask them if they have had any abnormalities. Those appointments are a lot more detailed. There's a lot of questions that are being asked if they've had, a history of gastric bypass surgery, any abdominal surgery. How long have they struggled with their weight? It's a lot more detailed appointment, I would say, with those types of patients. But yes, we do offer those GLP injections to those patients.
And what sort of things would you consult with Dr. Jones about?
I would say if it's something that I am not familiar with, if it's a specific medication that I'm on the fence about, I'm not comfortable prescribing. If a patient's asking if they can have more of a certain medication, possibly if there is a patient that, potentially not doing as well as they should be. Like if I had started the 25-year-old on antibiotics and after my follow-up in a couple days, she seems to not be doing very well, I would probably consult with Dr. Jones and just let him know that I'm going to, ask her to please go to her local urgent care or emergency room just to follow up with someone so they can see her in person.
Thank you. And how often do you meet with Dr. Jones for routine chart reviews?
I would say probably we speak on the phone pretty often. So, we meet at least monthly, but for actual chart reviews, I would say, to be fair, probably quarterly. He has access to all my charts within Push. So we collaborate. As he had mentioned, we cover over, I think it's 33 states right now.
Are excuse me, are you aware of the Mississippi rule for monthly chart reviews and quarterly meetings?
Yes, yes. So I was reading on that. So it looks like you guys require quarterly Zoom meetings with your collaborating physician, in addition to 10% of chart reviews or 20, whichever is less.
Right, right. Thank you. Thank you.
And if you don't mind, I was just gonna make note, you know, I was looking to see specifically in Mississippi how I could be of help to your state. And I think I had mentioned to you that I do I do all non-insurance based. It looks like when just doing my homework, and correct me if I'm wrong, but it looks like 10.5% of Mississippi is uninsured compared to the national average of 8%. So I feel like that could potentially help a lot of your you know, your community in Mississippi. The other part of it too is part of that uninsured is 26% of that is Hispanic, Spanish speaking, and I'm bilingual. I'm full Mexican. So I would say a big part of my patient population out here in California is Spanish speaking. And so I feel like my language, you know, capabilities can definitely bridge that gap.
So thank you for that. A couple of additional questions that I have. First, how do you guys address, so I understand your passion is working with underserved communities and this possibility for improving access. I guess my question is, that's one of the areas where you work. Is that all of Push Health, or is that just specifically what your practice entails?
Sorry, and I guess I'm a little confused by the question.
As we're speaking about cash only and not being insurance based,
Right.
because you mentioned that. So I guess my question was, is that a Push Health issue, or is that just something that you do? Because what I'm trying to figure out is, as you say that, so again, we go back to the same 30 people that have logged on in Mississippi,
Right.
and say 25 of those people are uninsured, and somebody else from Push Health picks them, are they all going to have the same type of cash only, non-insurance based thing? Or is it going to be one of those where they may be picked by another provider who actually does take insurance and does something totally different?
Yeah, no, that's a good question. Yeah, so Push Health is all non-insured.
Okay. So it's not really non-insured. It's just that you don't take insurance for your services.
Correct. Correct. And in fairness, a lot of the patients that we do get are not insured. So they'll communicate that with us as soon as they log in, and they say, you know, I haven't been feeling well. I don't have insurance right now. I just lost my job, etc. So I'm not saying that for all patients, but that is the case for a lot of the patients that we do get. They communicate with us as soon as they log on.
Mm-hmm. Okay. And then what's your process for referrals for patients whose acuity kind of outmatches what you are able to provide?
Yeah, so if it's something that I will say, it seems like Push has a very good filter as far as the questionnaires that are sent to them. So if there's something that seems to be beyond what can be done through telehealth, I don't think that it allows them to be put in the queue.
So if I was a 25-year-old person with UTI symptoms who was also having chest pain, I probably wouldn't end up in the queue.
Would not, yeah, absolutely. You would not. I think as soon as you mention anything about chest pain, you would not end up in the queue.
Thank you. I think I just wanted to echo, and I think Dr. Lippincott, I realized that we didn't necessarily introduce all of us, but Dr. Lippincott's the vice president of the board, and he did a really good job of just emphasizing that we are a collaborative state. I think it's important when we talk to people who have practices in other states or who are engaged in the practice of medicine in other states, that they understand kind of what the rules and regulations are as it pertains to Mississippi. And I heard you articulate them very well, but I always like to make sure that people understand that especially when they're involved in various types of practices across the country.
Absolutely.
I think I think that's it for the questions that I have. Anybody else have any questions for our guests this morning? Hearing none, I would just say, is there anything else that Dr. Jones, I want to make sure that I've given you an opportunity to say everything that's on your heart.
Sure.
Campos has done a really good job of fielding the questions that we had initially. Is there anything else that you'd like to add?
I guess I would just thank everybody for their time and hearing us out today. I would, again, just kind of like I said earlier, we are enjoying taking care of people in other states, and we're just kind of hoping to have the opportunity to help some patients in your state as well. We have a pretty good protocol, and meaning there's parameters that we operate within, and if they're outside of those parameters, we push them on to in-person care, and so we're not trying to take care of everybody. We feel like there's a niche, of people that can be easily helped online, and we want to do that for them.
Thank you very much. All right. Hearing no other questions, I'll entertain a motion.
I move that we close the meeting in order to consider going into the.
I need you to you need to be on, you
Thank
need
you.
to be mic'd.
Thank you. I make a motion that we close the meeting to consider a motion to go into executive session to consider this request.
All right. So it's been moved and properly seconded that we close the meeting to consider whether to go into executive session. Any further discussion on that? And hearing none, all in favor?
Aye.
There are no opposed, any opposed? Nope. All right. Meeting is closed. All right, we are now back in open session, and Dr. Kennard, our acting secretary, will give the findings from executive session.
Yes, we appreciate your participation today. We are going to deny the licensee's request for an exception in Part 2615, Chapter 1, Rule 1.2 and 1.6 at this time.
Are they still on? Okay, good.
I am still on.
All right, good. Thank you so much for your time.
Could I ask you a question? Is there more clarification or any more information on the denial?
Yeah, absolutely. So if you would like more information, we ask that, so typically what happens is you'd reach out to the executive director, and the executive director will give you specifics.
Okay. Thank you so much.
You're welcome. Bye-bye. Moving on with the agenda, the next item is, let me find my agenda. The appearance of Dr. Stephen Taylor, Dr. Stephen Taylor and Deborah Gross.
Good morning, Dr. President and members of the Executive Committee. We are, I just want to make sure that are you ready for us to start at this point?
Yes, we are. Thank you so much for being here this morning. I must admit, Dr. Taylor, when you first spoke, I was expecting you to say Birmingham, and you said a different place.
Actually, at my home at the moment. I will be in Birmingham tomorrow because that is where I see patients in our Birmingham clinic in person. And that's where I'll be tomorrow.
Got it. I just I have dual citizenship, so Birmingham is the other half of my dual citizenship.
I see. Yes.
Yes. So why don't you? And if you would like to just have the floor, we'll give you an opportunity to tell us what your request is today. So a little bit about your background and your practice.
Certainly. So, as I said, I'm the Chief Medical Officer of Pathway Healthcare. I am, by training, a general psychiatrist, a child and adolescent psychiatrist, and an addiction psychiatrist. I'm board certified in all three of those areas and specialty and subspecialties, and I'm also board certified in addiction medicine. And Pathway Healthcare, our company, has offices in several states, but relevant to this meeting, we have offices in Columbus, in Jackson, in Vicksburg, and in Laurel, thank you, Laurel, Mississippi. And so our offices provide treatment to patients with general mental health conditions, addiction disorders or substance use disorders, and a combination of mental health and substance use disorders. It's all outpatient, and our care is provided both in person and by telehealth. Dr. Gross is the medical director and is our state director for the entire state of Mississippi. And Dr. Gross can tell you more about herself.
I'm also an addictionologist and a psychiatrist, boarded in both of those things. I was in practice, solo practice for 25 or 30 years in Mississippi prior to coming to work with Pathway, where I've been, I meant to look this up, but I forgot. 5 years, Dr. Taylor, 7. And at our request, partly I've been collaborating with nurse practitioners since I started with Pathway. And the initial collaboration was done as well as a full-time practice. And so then I decided that I wanted to retire from direct care, but I have continued to collaborate with the nurse practitioners since that time as well. I meet with them about once a week, sometimes training new people who've not done addiction work or people with addiction experience who haven't done psychiatric work, so that we can deliver to our patients the combined treatment that we think is the best way to treat these things. Co-occurring disorders being a large part of our practice. I guess, does that suffice?
Yeah, we will have additional questions, but I think that's a good overview.
Okay.
And so you said that you were in practice here. The reason that is listed for your appearance is as the exception to the 2080 hour in-state physician practice requirement. And so can you help me understand what your practice looks like now and where you're located? Because I'm just trying to figure out where the exception comes in.
I'm located in the Jackson office. It's North State Street is down there by Baptist. That's where my office is and where the patients go. Most of our addiction patients come in person for their labs, and to get their initial appointment, although we are moving increasingly toward the telehealth model as is being recommended by a lot of the addiction societies that we and research for getting the accessibility up for some of these folks with really severe addiction disorders. So, but the physical location, I do mostly telehealth now. And I do not see patients directly now. So that is the question, I think for myself from the waiver standpoint. And I guess that answers does that answer your question, what you wanted to know?
Yeah, I think it at least provides some clarity to the current practice, what your current practice is like.
Yes, I do a good bit of, for our whole company, a good bit of, we are working toward getting the collaborative care model in place for being able to provide help in areas that are super underserved with some specialty care in terms of the collaborative care model to primary care for psychiatric and addiction services. But that's a process, learning the rules and the Medicare, the way that all works, how to bill it. It's more complicated than I could have ever imagined, but
and I can,
that's one of our goals. Go ahead. I'm sorry, Dr.
I
Tyler.
didn't mean to interrupt Dr. Gross. I wanted to also point out that as a board certified child and adolescent psychiatrist with about 30 years of practice experience, but not in the state of Mississippi, but with that experience, both child and adolescent, general psychiatry and addiction psychiatry, one of the projects that we are involved in the state of Mississippi specifically is to start taking care of adolescents with general mental health and substance use disorders. Up until now, and very recently, we have been in discussions to change this, but up until now, we have only been taking care of adults age 18 and up. But that is very soon going to change. We'll start seeing some adolescent patients as well.
And so, Dr. Taylor, is it your intention, and I just was going back to the documents that were submitted. So it was your intention just to be able to serve as the backup person for Dr. Gross? Is that my understanding? Or is it your intent to be engaged in oversight or collaboration outside of a backup role?
No, your question is correct, Dr. Owens. And my goal is to serve as the backup for Dr. Gross, times when she is, on vacation, or if God forbid sick, or some other reason unavailable. My goal is to be able to serve as a backup. It does also happen to be the case that for even currently, and in the past several years, when Dr. Gross has a question, or some of the nurse practitioners have a question regarding a difficult case, or a complicated clinical situation, they always have access to me. They will freely contact me, run the case by me, and I serve in a collaborative and an advisory role in that regard anyway. But my real purpose specifically for this is to serve as a backup to Dr. Gross.
Thank you. Any additional questions?
Thank you, Dr. Owens. I'm Ken Lippincott. I'm a psychiatrist from Tupelo, and I'd just like to clarify. My understanding is that the request is for an exemption from the mileage rule and the 2080 rule for Dr. Taylor. Is that correct?
No, the request is the exception really for both of us. For Dr. Gross, an exception to the 2080 rule, since she does pretty much exclusively telehealth work. And the rule does specifically say, does not include telehealth. And then as far as the distance requirement, since I am licensed in the state of Mississippi, my understanding from my reading of the regulations was that as a psychiatrist, I count as a primary care physician, and therefore that distance requirement would not apply to me. So that's my understanding of. So for me, it's more the 2080 rule as well as for Dr. Gross.
Okay, thank you. Yeah, thank you for clarifying that. I don't have any other questions.
Dr. Kennard?
Are any of your nurse practitioners in attendance today?
No, sir.
Okay, thank you.
And so I know you all have mentioned that there were several locations where you have a footprint. I think according to the information that I see on the application, it's a total of 4 nurse practitioners that work with you all. Is that correct?
Mississippi, one of them is not working with us anymore, Miranda. I'm not sure who's on the list right now, because we had a recent change in our staff, but we have 2 in Mississippi, and I guess that's the only 2 that count. We do have several other nurse practitioners. Some of them don't work in Mississippi. They work in one of our other states, like Tennessee or Alabama.
That's right. But the 3 that we have that we are included in this petition would be Stuart Myland, Ryan Doty, and Cheryl Cooper.
Those
Cheryl. Oh, don't tell her I forgot her. She'll get a complex.
Well, so those individuals are all included on the application. Licensed at least are listed on the license application under practices and collaboration. And you said that Thurman is no longer included in that group, but was the other individual that was listed. So if it needs to be updated, that's fine. I just wanted to make sure there weren't any other individuals that were a part of this that were not actually included in the documentation that we had in front of us today.
No, ma'am.
I have another question. How long have you been licensed in Mississippi, Dr. Taylor?
I have to check to be certain. It may be 2 years.
Okay.
But I need to double check that.
I saw your application was dated in September and I was just curious.
Yes, that's when we applied for this, but no, I've been licensed in Mississippi for at least 2 years, and I can check and give you the exact duration.
That's fine. Thank you.
Yeah, hand grenade guess is good enough. You can just be close. You don't have to be that precise.
All right, thank you.
All right. Any other questions from the executive committee? And to our guests, is there anything else that you wanted to mention or that you feel like we haven't had a chance to ask or bring out that you feel is important? All right.
Thank you.
Thank you. Appreciate your time.
Hey, so at this point, I'll entertain a motion, and I would like for you guys to make sure your mics are on.
So moved.
So wait,
To
but
motion to close the meeting to consider going into executive session
okay.
to discuss this further.
I second that motion.
All right. All in favor?
Aye.
Aye. And that means it's unanimous. All right. So the meeting is closed and we will be back shortly. So, after our discussions in executive session, there was the determination that more information was needed. And so as a result, no action was taken on the submitted requests. For Doctors Taylor and Gross, I do have a couple of, we needed some additional information. So there were some issues that we wanted to clarify with you. So if you could just, they can require your response either now, or you can choose to deliberate on it and address it at a later time. So the first thing is, we just want to confirm that Dr. Gross is not currently engaged in direct patient care a minimum of 20 hours a week. That the work that she's doing has transitioned now to being entirely telehealth. Is that accurate? We want to make sure that I have that correctly.
Yes.
Okay. All right. So taking that into consideration, the request that has been submitted for the executive committee's consideration is inadequate to cover the practice in the way that you have described or that you have requested. And so as a result, I would like to at least share with you what the appropriate request would be to reflect the practice that you all have described for us. Okay?
Yes.
So starting, that would be that there would be a need for 2 separate requests for waivers for each of you. Under those 2 separate requests, and we'll start with Dr. Taylor first. Dr. Taylor, the request should be the one that you've already submitted, which is an exception to the 2080 rule. But the primary care designation does not apply to individuals who are out of state. So that 75-mile rule would actually apply. So then you would also need to request a waiver for the extended mileage rule in order for you to be able to serve as a backup for Dr. Gross in the way that you have described to the executive committee. Okay, so that first. And then Dr. Gross would need her own request for an exception to the 20-80-hour rule because she is not engaged in independent practice a minimum of 20 hours a week. So at this point, you have options. One would be that you could withdraw this request and think about it, or we would like to offer you an opportunity to amend your request to reflect what I have just proposed or informed you. And then we can make a decision on that based on your decision. And if you have any questions or need clarification, we are happy to provide that as well.
Just one question. With respect to that second option, amend the request to reflect the instructions you just gave. That would be something we would submit in writing, and then the decision would be made at a subsequent hearing of this type. Is that
No.
what?
So what we were going to give you the option to do is to verbally amend that, and then you could submit that paperwork or update the request after, and we could consider it pending the submission of the request as we are discussing right now.
I see.
So that would give you the opportunity. We could make a determination or at least consider the waivers today, but of course they would not be in effect until we actually were in receipt of the appropriate requests to reflect what our decision might be at that time.
I see. Well, I will go ahead and say that my choice would be option 2, which is to amend the requests as described in your instructions, and to request for myself the waiver of the distance requirement as well, in addition to the request that I've already submitted. And Dr. Gross, I'll leave you to express the request that you need to express.
Yeah, I appreciate the offer of going ahead with it today, so that I would like to go ahead and amend it today the way you said. Is somebody write it up, or how? I think I'm not quite since we had all this writing to do beforehand. Somebody there is going to write it up, or you'll just take it as a verbal
So for right
request
now, for the purposes of
for
this
right now.
thing, we will take it as a verbal amendment, and then we can, again, you can work with our staff to make sure that the appropriate requests are completed.
Good.
And we really appreciate that. And so, yeah, I think Dr. Gross's request would be for an exception to the 20-80-hour rule as you have described.
Okay. So at this point, I will, are there any additional questions related to this? Hearing none, we will take each of these requests separately. So at this time, I would like to entertain a motion.
Make a motion that we take up Dr. Taylor's request as stated.
Okay, so Dr. Kennard, just to clarify, your motion is that we approve the waiver requests for Dr. Taylor, which are the 2 requests, one for the 2080 rule and one for the extended mileage rule. So to approve the request for those waivers. Is that your motion?
That's correct.
Is there a second?
Second.
All right, any discussion? Hearing none, all in favor? Aye. And that's unanimous, okay? For the next item before us, which is the amended request of Dr. Deborah Gross to be granted an exception to the 20-80-hour in-state practice requirement. Is there a motion?
So moved.
So move to approve, Dr. Kennard, for clarification.
Move to approve.
All right.
A second.
So it's been moved and properly seconded that the amended request of Dr. Gross for an exception to the 20-80-hour rule be granted. All in favor?
Aye.
Aye.
Aye. My ayes have it. So Doctors Taylor and Gross, thank you very much for being here today and for your willingness to kind of move forward and provide the additional information. And you can touch base with our board staff to make sure that the information is completed appropriately.
Okay.
Thank you all very much. We really
Thank
appreciate your time and your consideration.
Appreciate it.
Thank you.
All right, next item on the agenda is the Zoom appearance by Dr. Nicholas Chamberlain, who is accompanied by Ms. Wade. And this is a request for an exception to Rule 1.4, which is extended mileage in collaboration with nurse practitioner and to the 20-80-hour in-state physician practice requirement. Doctor?
That's correct. Good morning to the board. We're also requesting the exceptions to the 2080 rule and the extended mileage exception for Dr. Hall, who is the backup physician. He's also joining us on the call.
Let me see if do we have that documentation for Dr. Hall?
You should have. I know I was corresponding with Mr. Dalton earlier this week. And he said that the documents that we had previously provided were sufficient, but I also provided an amended letter signed by Dr. Hall and Dr. Chamberlain yesterday to Mr. Dalton in abundance of caution. But he told me that we had all the paperwork necessary to go forward with both of the requests this morning.
Well, we for sure have the amended, or at least the signed document on the practice agreement and other things. So that does include his name.
Yes.
And we also have the letter that's signed by both of them.
Yes, ma'am.
Okay. All right. So nothing about 1 second, please. All right. Thank you for that, for your patience. All right. So, with respect to Ms. Wade, we typically allow the licensees to speak first. So if Doctors Chamberlain or Hall are here to speak to address the executive committee, we'd like to open the floor and give them the opportunity to do that and explain the nature of their requests and also their practice. And we'll make sure everybody's unmuted and able to speak.
Okay. Dr. Owens, this is Dr. Hall. Should I proceed?
Absolutely.
Okay, thank you for the ability for us to come back to the board and to talk to you about our work in Mississippi and our desire to have our nurse practitioners be able to take care of patients in the state as well as Dr. Chamberlain and myself. I just want to say I have great affection for the state. Grew up in Mississippi in a little house on Keener Avenue and walked through Millsaps College to elementary school every single day. So I maintain a lot of affection for the state. Dr. Chamberlain, who is with me, is actually a graduate of University of Mississippi Medical Center, and he'll speak to that. But just to give you a little overview of what we do, we primarily provide biomedical HIV prevention services, which is HIV PrEP, non-occupational PEP, initiation of antiretroviral therapy for people newly diagnosed with HIV, as well as some longitudinal care where appropriate for people who are actually diagnosed with HIV, exploring related services such as STI care and bacterial STI prevention. So, we believe that our model, which is telehealth based, is important just because not only are folks often geographically separated from these care opportunities because of the limited number of brick and mortar clinics who do this work, but also there's stigma that, inhibits individuals to seeking such care because they simply don't, want to go to a brick and mortar setting and feel more comfortable in a telehealth setting working with providers who are experienced in this field like our own. So, we believe the model is not just about convenience, but it's really important in terms of reaching the people who need to be reached. And we know we have quite a commitment to the Southeast US, as well as Mississippi, where we know, rates of new HIV infections exceed the national average. So it's an important commitment of ours, and Dr. Chamberlain and I have enjoyed providing services in the state and really want to be able to increase our capacity. We only have started with the two MDs since July. We've had 213 individuals enroll in services in Mississippi. We've actually completed visits for 44 who sought actual, synchronous video visits with us. We completed 44 visits. 6 of those were in women, which is a really important population of ours to reach. So and I'm certainly able to answer other questions about the care we provide and our goals in providing that care. But, we realize it's important to stress to you that our model involves consistent communication between our nurse practitioners and our MDs really on a daily basis. And our platform that we built from scratch, there's a capacity in there for the nurse practitioners to reach out to their supervisor in a chat feature right there in real time if they have any questions. We also maintain a backup through Microsoft Teams, we have many, many, many threads in there going in terms of the clinical care issues that we address. And then, of course, the chart review consistent with Mississippi requirements monthly would be planned in these relationships, as well as the quarterly meetings. We are very rigorous in terms of our compliance with CPA requirements in all the states that we practice in, so would be just as dedicated to it in Mississippi as elsewhere. Since I tend to speak a lot, I'm happy to stop there and answer questions that you may have about our practice or our proposals. And Dr. Chamberlain, did you want to add anything to anything I've said?
Nothing. First of all, good morning, everybody. Dr. Chamberlain here. Nothing yet, Dr. Hall. Thank you so much.
Great.
Just really quickly, can the two of you just run through your education and your training for the benefit of the
Sure. I have been working in the field of HIV for my entire career since 1987. After doing some policy work, went back to medical school at Johns Hopkins, completed my internal medicine residency at Brigham and Women's in Boston, my infectious diseases training at University of California, San Francisco, and the State Health Department in California, where I also did an STD fellowship there at the state. So that's, and since that time, I've been a medical director of brick and mortar clinics doing HIV care and prevention until about 5 years ago when I began working in remote care, what I call remote care. And again, this is predicated on the notion that we were not reaching everyone who needed to be reached to achieve our outcomes. We needed to provide new ways of getting people to care in a stigma-free way. And that's why I've been so devoted to kind of care we provide here at Q Care. Dr. Chamberlain?
So I'm also originally from Mississippi, originally from Columbus, Mississippi, moved to Jackson, Mississippi, maybe around 11 or 12 years old. Went to undergrad in Rhode Island and then came back and did my medical school residency in internal medicine and infectious disease fellowship at the University of Mississippi Medical Center. Finished that 3 years ago, a little bit more than 3 years ago now. And pretty much since then, I've been working in HIV treatment and prevention as the medical director of an HIV clinic in Atlanta.
Awesome. Thank you.
I would just add one little snippet to that, which is we came by, Dr. Chamberlain and I both work. Our organization actually maintains a brick and mortar clinic here in Atlanta, Georgia. It's where I met Dr. Chamberlain, who also came recommended by Dr. Leandro Mena, who all of you know, I'm sure know from University of Mississippi, who is a very important person in our field. We at our entity report our achievements really to CDC and the Division of STD Prevention, where Dr. Mena was the director until I think last year. So yeah, so Dr. Chamberlain comes highly recommended by Dr. Mena, if that makes a difference.
I love that. Leandro has a footprint everywhere. He's a good friend of mine. And I was wondering, Dr. Hall, you might also be familiar with Dr. Jean Anderson, who was doing quite a bit of one of my former attendings who did a lot of early work on HIV in pregnancy and in the female population. 20, gosh, I can't believe it's been 25 years ago. But yeah, so
Yep.
it's a pretty small community, but doing very
Mhm.
impactful work. So are there any questions at all from the executive committee?
Uh, so, just to clarify, yes, for an exception is for Dr. Chamberlain for the 75-mile rule and the 2080 rule. And is Dr. Chamberlain the primary collaborator with these nurse practitioners?
Yes, sir, that's correct.
And do these nurse practitioners have a backup collaborator?
I'd be the backup collaborator,
Okay,
Dr. Hall.
Okay, and and you're in Atlanta also, Dr. Hall, is that correct?
I actually am, our headquarters of our practice is in Sarasota, Florida. I spend a lot of time in Atlanta because we have a brick and mortar clinic that we run there. So I'm actually Florida, Georgia.
Okay, I just wanted to clarify that. Thank you.
Any other questions? Hearing none, I will entertain a motion.
I'd like to make a motion that we close the meeting to consider whether to enter into executive session on this matter.
Second that motion.
It's been moved and properly seconded that we close the meeting. Any further discussion on that? Hearing none, all in favor? Aye. Thank you.
Hi, can you hear me online? Okay, I'm Paul Barnes. I'm the board attorney. This is Jonathan Dalton, investigations director, and who also personally handles the exemption request. The committee asked us to ask you that has anything about the practice model changed since Q Care Plus last made a request for an exemption in May, at which time it was denied. Now, there are new personnel, but the committee is asking if there have been any changes to the practice model. So if any one of you could speak to that, we would appreciate it.
The practice model is essentially unchanged, but I'd be happy to answer any more specific questions about particular aspects of it.
I think that's all we needed to know, Dr.
Okay,
Thank you.
sure.
right. We are now back in open session, and Dr. Kennard will share the decision of the executive committee.
Thank you. The committee is denying the request for exception for Dr. Chamberlain, the original exception for request on Rule 1.4, extended mileage, and the 2080-hour in-state practice requirement. And the amended request by Dr. Hall is also denied for the same request.
Thank you all very much for your time, and we appreciate the good work that you're doing. Thank you.
Thank you for having us.
At this time, we'll hear from our executive director for the update. Just kidding. Are you prepared to speak on his behalf or no? Oh, you are? Okay, fantastic. Oh, we're doing
this correctly? Or we can wait.
So typically for this one, we don't do the slides report. He usually does the slides for the full board, but if you want to give the EC a little something special, we'll take it.
Well, we'll just
Whatever.
work. I'll work from my documents here. We can go to it. As of our time, September through October, we issued 117 license to physicians and DOs. We issued 20 physician's assistants and 1 acupuncturist. Compact license, we issued 224, letters of qualification 15. Certifications issued was 456. In investigations, we received 93 complaints, 24 were closed, 12 were open, for a total of 62 cases that are currently open. Cases closed within 7 days is still running about 64%. PMP reports requested were 22. Of those resulting in investigations, there were 11. I'd like to add that Dr. Cleveland is on his way back from the IMLCC, in which he was just elected vice chair and representing that organization and representing the state.
Awesome.
And that concludes the executive director's report.
Awesome. Thank you so much. All right. I think that concludes the items on our normal agenda. And so we will adjourn our executive committee meeting, take a bio break, and then resume with the meeting of the full board.